Many thanks for your very kind invitation. Good morning, everyone. It's my great pleasure to be here and make some brief introduction of our recent works. My name is Dong Yi from Zhongshan Hospital, Fudan University. Today, my topic is the contrast-enhanced ultrasound features of pancreatic neuroendocrine tumors and preoperative prediction of tumor grades. Pancreatic neuroendocrine tumors, we can also call it as PNETs, is a very uncommon neoplasm which only account for 1 to 3% of primary pancreatic tumors. The pathological grades of PNETs could be correlated significantly with the prognosis, and high-grade tumor is considered a poor prognostic factor for survival. So to make the preoperative distinction of the tumor pathological grades has critical implications for the clinical decision-making process. For the treatment strategies of the PNETs, it has notably related to the pathological grades of the PNETs. The low-grade tumors could only be surgical removed and follow-up. However, the high-grade tumors may need various treatment options, such as their targeted therapy or chemotherapy. According to the current WHO classifications, the PNETs could be divided into 3 categories according to the cellular proliferation index, Ki67, and mitotic count. The grade 1 is the Ki67 index less than 3%, and the mitotic rate is less than 2/10 HPF. And with the increase of Ki67 and mitotic rate, the tumor grade will be upgraded. From the surgical strategic view, we might have different attitude towards the different categories of PNETs. They can be divided into 3 categories. The first one is that must not be operated. For this categorization, there should be the G3 PNETs, or the PNETs which prove to have been poorly differentiated. And the PNETs that might be not operated could be followed up are those with smaller size, always size smaller than 2 centimeters and without any symptoms. And the PNETs that must be operated are those larger ones, larger than 2 centimeters and with function. According to current AFSON guidelines of the CUS of pancreas, when we inject the contrast agency for the patients, we can observe the different phases enhancement. During the arterial phase, we can make some differentiation diagnosis depending on the different enhancement features of the tumors. However, during the venous phase, we could have time to watch or to observe the pancreatic vascular invasion, and during the very long late phase, we can make the whole scan of the liver to detect any possible liver metastasis, and especially those which could not be very obviously seen on the conventional B-mode ultrasound. For the principles of contrast-enhanced ultrasound, depending on its arterial phase enhancement, we might have the initial diagnosis of different types of pancreatic tumors. For the pancreatic adenocarcinoma, it always showed hyper-enhancement during the arterial phase. However, some of the PNET might show the hyper-enhancement, and the locally tumor-like AIP, which means the autoimmune pancreatitis, may show the ESO enhancement. So the purpose of our current study is to compare ultrasound and CUS features among different pathological grades of PNETs, and we also want to evaluate the usefulness of ultrasound and CUS features in diagnosing the pathological grades of PNETs. And this was a single-center retrospective study which was conducted in our hospital for nearly 2 years. And all the PNETs were histopathologically confirmed either by biopsy or by operation. The ultrasound contrast agency we used is SonoView. During our observation, we just recorded the ultrasound features, both of the B-mode ultrasound, the enhancement degree, and enhancement patterns of different tumors. As a result, we got 49 patients finally included. According to their pathological grades, they could be divided into the G1, G2, and G3 groups. And all these lesions were pathologically proved. Let's have a look at this case. This is a very small lesion located in the tail of the pancreas. It's really very small, that's smaller than 2 centimeters, and no colorful signals could be detected. After injection of the contrast agency, we can notice that during the very early stage from the arterial phase, this lesion showed obviously hyper-enhancement. You can see that it's right here. Very obvious hyper-enhancement compared to its surrounding liver parenchyma. And this hyper-enhancement lasted for the whole venous phase and late phase. Finally, this lesion has been proved to be a G1 PNET. Its Ki-67 index was less than 2%, and the mitotic rate was less than 2/10 HPF. We could notice that this lesion was hyper, and hyper enhancement. This is another case. This lesion is relatively larger than the previous one, and it was located on the head of the pancreas, with relatively clear margins and a very homogeneously hyperechoic lesion. However, its contrast imaging features show that this lesion was also hyper-enhanced during the arterial phase, where it turned to be the acyl enhancement during the venous phase and washed out during the late phase. This lesion was finally proved to be a G2 PNET, and comparing to the previous one, we can notice that this lesion should wash out during the late phase. Let's look at this lesion. It was also located in the head of the pancreas. However, this time we can notice that the obvious dilation of main pancreatic bile duct to the distal of this lesion. After injection of contrast agency, were quite different from the previous cases. This lesion showed the hyper-enhancement from the arterial phase to the venous phase and also to the late phase. The lesion was proved to be a G3 PNET finally. So we can get our very initial results that might be some relationship between the CUS features and pathological grades of PNETs. From the enhancement degree, the arterial phase hyperenhancement is more commonly seen in G1 and G2 PNETs, where the late phase hyperenhancement is more commonly in G3 PNETs. Meanwhile, we can also notice that the non-enhanced areas could be detected in G2 and G1 PNETs, but never in G3 PNETs. Further, with the updated software of the ViewBox, which was provided by the Bracco company, we can make further analysis of these lesions. We can put two regions of interest, both inside of the lesion and outside of the lesion. We can create two time intensity curves, and after the curve fittings, we could get some parameters to quantitatively evaluate the difference between the different pathological grades of PNETs. So make a very brief summary that the preoperative non-invasive prediction of PNET tumor grades is important to clinical decision-making of treatment strategies. And some of the contrast-enhanced ultrasound features might be helpful for us to make the preoperative prediction of these grades. And also in the future, the dynamic contrast enhanced ultrasound might be a very promising way to make quantitative diagnosis and evaluations. Last but not least, I'd like to thank the multidisciplinary team of pancreatic tumor in our hospital. Based on their great support, we have some cases to discuss here. Thank you for your attention.